Fantastic. And good morning, everyone. Welcome. Thank you for joining us for today's Knockout Opioid Abuse Day Learning Series webinar on this last day of July, Responsible Opioid Prescribing. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for one EMT elective CEU. And the Partnership for a Drug-Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers. And this program today is eligible for one maximum Category A hour or continuing education unit. Faculty member today, Rebecca Bush, discloses that she serves on the advisory board for Baxter and received grant and research support from Nestle Nutrition. And PA planner Dean Barone discloses that he serves on the speakers bureaus of Ethicon and Johnson & Johnson, and all other planners, faculty, and reviewers have no relevant financial relationships to disclose. All relevant financial relationships have been mitigated. And if you wish to claim CME or CE credit, you must do so within 30 days from today's date. And after that point, we'll no longer be able to issue you credit. And as mentioned earlier, you'll have information on how to obtain credit later on in the webinar. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares and the New Jersey Office of Alternative and Community Response and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them all for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. So I'm so pleased to welcome today's expert faculty. I think we're going to have a really great conversation. First, we have Dr. Rebecca Bush, who is with us. Dr. Bush is a board-certified general surgeon and surgical critical care specialist. She currently serves as the co-director of the Opioid Stewardship for Surgical Patients Initiative with the Surgical Collaborative of Wisconsin. And we have Dr. Jeffrey Lazick, who is a pharmacist and the administrator of the New Jersey Prescription Monitoring Program, NJPMP. And I thank you both for being with us. I think we're going to have, as I mentioned, a great conversation. And Dr. Bush, I'm going to turn the presentation over to you.
Great. Great. Thank you so much for having me and for the opportunity to share the work that we've been doing here at Surgical Collaborative of Wisconsin, or SCW, on our Opioid Stewardship for Surgical Patients Initiative. I know you all had Carla Gaines here talking with you last month, and so it was exciting to see someone else from Wisconsin speaking to you in this forum, but we definitely do not have things figured out here in Wisconsin. So thank you again for the invitation. Next slide. I don't have any relevant financial disclosures, although I will say that our work has been supported by a portion of our state's opioid settlement funds and appropriations from the state's budget of our Department of Health Services, as well as the Hendricks Family Foundation and other private donations not listed here. Next slide. So the stated learning objectives for this session are to identify state and federal laws governing the proper prescription and monitoring of controlled substances, evaluate behaviors that might indicate drug seeking or diverting, as well as approaches to patients suspected of misusing opioids, and recognize the link between responsible opioid prescribing and substance use prevention. I'm primarily going to focus on this third objective. Next slide. So within this objective, I want to discuss the role of surgeons specifically in opioid prescribing, introduce and share SCW's opioid initiative, or opioid stewardship initiative, and describe the role of providers in the opioid stewardship moving forward. So let's go ahead and get started. Next slide. So one question that you might ask is, why are we still talking about opioid prescribing in 2025? Yes, overdose deaths from illicit fentanyl have increased substantially over the last 10 years, and this is an area of greatest concern. But the mortality rate from prescription opioids has not changed since this class of drugs was recognized as the primary driver of mortality in the early 2000s. It went from 4.4% down to 4.2% over the course of the past decade. Despite our increased knowledge and awareness about the harms of prescription opioids, we have essentially had no impact on decreasing deaths related to prescription opioids in the past decade. So with this knowledge, why do doctors, and I'm going to focus on surgeons in particular, continue to prescribe opioids? Next slide. Well, one of the answers, and it's not a great one, is that surgery hurts. And for better or worse, opioid medications remain a mainstay of severe pain management with most surgery. But I will say there is increasing awareness of the long-term and societal consequences associated with opioid prescription among surgeons. Next slide. I will say, though, that this creates a problem. In the state of Wisconsin, surgical prescribing overall accounts for 46% of all new opioid prescriptions. And this is up from 38% in 2019. Now, the fact that opioids are prescribed for surgery is not inherently bad. After all, we noted that surgery hurts, and to perform surgery without some sort of discussion about postoperative pain control should frankly be seen as assault. But where surgeons have gone drastically wrong is in their prescribing practices. Patients are often given 50 to 75% more opioids than they use following common procedures. Next slide. And this is across the board from minor surgical procedures to major surgical procedures. And what researchers have found is that regardless of the size of operation that a patient undergoes, whether it's something relatively minor like an appendectomy or something more complex like a colon resection, a percentage of these patients will have a new persistent opioid requirement or use after surgery. And this represents a previously underappreciated surgical complication in my mind and in the mind of several others. Next slide. Next slide. Sorry. And prolonged opioid, go back. And prolonged opioid use following surgery is common. Approximately 4 to 10% of opioid naive surgical patients will become long-term users. And this really should be seen as one of the most common surgical complications that exists. This is a high frequency among our patients, with somewhere around 1 to 2 patients out of every 20 becoming a long-term opioid user. And that's a lot of patients. Next slide. So our current surgical practice of prescribing opioids to surgical patients leads to a percentage of patients developing chronic opioid use. Next slide. Secondly, excess opioid prescribing is common following surgery, as I mentioned, and leads to a supply of opioids available for diversion in our communities and illicit use. This is one statewide analysis from Michigan, where overall 75% of prescribed tablets were unused among 2,400 patients surveyed across a variety of minor and major procedures. Next slide. Again, our current surgery practice of prescribing opioids to surgical patients leads to potential for opioid diversion in the community. Next slide. And to go along with this fact, we know that about 90% of prescription opioids that are abused originate from provider prescriptions. And with such a large proportion of provider prescriptions originating from surgeons, it's easy to see how, taken together, next slide, we start to see how current surgical practice continues to impact the opioid epidemic. Further, when we think about where that 90% of opioid that patient abuse come from today, they're much more likely to come from a surgeon's acute pain prescription as opposed to a chronic pain prescription, where all the prescribed tablets are typically used by the patient. Next slide. So why do surgeons prescribe too much? We know overprescribing is a problem, but I think the answer is less straightforward and likely more multifactorial. It's not as simple as prescribe less. There are concerns about patient pain, of course. As I mentioned, we all need to make sure that our patients have some degree or understanding of pain control after surgery. Second, many surgeons trained during a period where pain was seen as the fifth vital sign. Sorry, of course, my pager's going off. Third, there's an aspect of patient and physician convenience. If a patient lives, an hour away from the closest pharmacy, it can be difficult for them to get get opioid prescription, and they might have to travel for it. In an era before electronic prescribing, it was more difficult. They'd have to go into a physician's office or travel to an emergency room in order to get a refill or something to that effect. So people would often prescribe to prevent that inconvenience. And then surgeons often had, would be seeing multiple patients a day. One surgeon that one of my partners talked to would see 60 patients a day. And so, you know, if one of those patients is asking for pain meds, it's really difficult to, try um, to triage the number of patients you're dealing with and educate and counsel and do all of those things all in the course of one day. So the time constraints also play a role in this, which is unfortunate but true. Next slide. So, as surgeons are part of the problem in creating iatrogenic opioid dependence by prescribing opioid pain medications following particularly minor surgical procedures, I kept coming across the questions of, are surgeons the gatekeepers in part of this opioid epidemic? Next slide. So the next part that I want to switch gears to a little bit is to introduce and share SCW's opioid stewardship initiative. Next slide. So what is SCW? So SCW is a surgeon-led practice change community that aims to improve surgical care by optimizing quality, reducing costs, and facilitating provider professional development across practice settings. And our vision is to ensure access to high-quality surgical care across Wisconsin. And so really you can think of this as like a giant QI initiative. Okay, next slide. And we have several initiatives that we have across the state of Wisconsin. So we established ourselves in 2017, and we have about 75% of the hospitals across the state of Wisconsin participating in SCW. And this involves over 430 surgeons and quality leaders. Next slide. Our initiatives focus on work varying from breast cancer, colonoscopy, and practice in rural surgery, but the one that I'm going to talk to you about today, or the one that I'm most involved in, is looking at our work in opioid stewardship for surgical patients. Next slide. So there are four major components that were established with this initiative in an effort to gain traction in the community and achieve buy-in from participating hospitals, administrators, and surgeons. To secure this, our team met with surgeons and drove around the state to individual hospitals and practices and sought feedback about what meaningful quality improvement would look like. Those early interactions helped shape what and how we do QI, and we still continue this iterative process. Our core components include four different sort of prongs. First, a data platform to provide confidential benchmarked performance reports to surgeons and hospitals. Second, a learning management system to deliver guidelines and best practices to facilitate discussion. Third, engage surgeons and team members at each hospital. Fourth, strong partnerships with professional societies, payers, and quality improvement organizations. Next slide. Shortly after developing of SCW in 2017, one of our first initiatives was to reduce this excessive opioid prescribing. We developed a multifaceted intervention consisting of surgery-specific prescribing guidelines, actionable education to opioid-sparing acute pain management spanning the perioperative continuum, and providing individual surgeons with their own prescribing data, which was tracked over time. One thing that was unique about our program is that most of our intervention is targeted at the prescriber level. We started out providing individual surgeons with their own prescribing data, which was tracked over time through performance reports. And this is an example of one of our performance reports. And so this is an individual surgeon labeled as Surgeon X, and you can see sort of where they stand in comparison to other surgeons prescribing doing the same procedure across the state of Wisconsin. We have the red line here representing the average prescription across the state of Wisconsin, and the green line representing what our sort of goal average for prescribing practices would be. And so what the surgeon could see here is how they compare to their peers from their prescribing data, and they can also track this over time. Next slide. Between 2017 and 2023, we have distributed over 6,000 benchmark performance reports for surgeons. We also provided this information to hospitals so that they can compare themselves at the hospital level in comparison to other hospitals within the state. We've also started looking at this data on a county level in hopes to potentially engage counties from their sort of opioid settlement related standpoint to improve and invest within their communities from that standpoint. Next slide. As part of our learning management system, we also created education on acute pain management and opioid stewardship that also met provider criteria for MATE Act requirements and free CME to further encourage engagement. We then expanded this with a comprehensive course intended specifically for surgical prescribers, including APPs. Next slide. So this was a 3-hour CME or three CME credits that was free to all providers. And they could just access it and use it, and it counted toward the criteria for the MATE Act. Next slide. We also created video to assist providers on patient counseling to cover pre-op, peri-op, and post-operative periods with actionable information that could be easily incorporated into their practice. And the idea was meant to sort of really provide just very how to incorporate this information quickly within the short time constraints of their visits. Next slide. And then one of the other things that we did is we developed and distributed surgery-specific prescribing guidelines. And this was intended for opioid-naive patients and as a starting point for a discussion between the patients and the surgeons. Next slide. And so this is what this looks like. And so we handed these out, and these are some of the most popular things that we hand out at our meetings and our residents. We have these printed out on little like badge cards for them so they can have them on their ID badges. But essentially it lists different procedures as well as recommended discharge prescription oxycodone equivalent tablets for each specific procedure. And so that just serves as, again, a starting point for our opioid naive patients to help reduce excess prescribing. Next slide. And as can be seen from this data from 2019, this is not our work, but prescribing less is safe and feasible. In this study, they went from prescribing usual doses to now prescribing these less than recommended doses that were on the aforementioned slide. And they found no differences in satisfaction score and no differences in pain scores. So prescribing less was both safe as well as feasible and viewed just fine by patients. Next slide. And this also did not lead to an increase in phone calls, which was one of the primary fears of providers as well. Next slide. And another thing that we did was we delivered actionable education on opioid-sparing acute pain management strategies in the perioperative period. Next slide. So on the reverse side of those prescribing guidelines, we provided sort of other alternative pain management strategies for the preoperative, perioperative, and postoperative period to try to encourage alternative pain management strategies outside of just opioid medication as a means for pain control. And so these are alternative or adjunct methods that could alternatively or in addition be used to the opioid medications. Next slide. And so overall, we would say that this has been a large success for us. So 100% of our SDW hospitals have participated in the Opioid Stewardship Initiative. And overall, surgical opioid prescribing in the SDW hospitals has decreased by 50% for common general surgery procedures since 2017, although overall we remain above recommended guideline levels. This has overall resulted in greater than 85,000 fewer tablets per year entering our communities following just 4 common surgical procedures that we've studied. And we've had close to 600 CME credits claimed at no cost to surgeons. Next slide. And lastly, I just want to describe the role of providers in the opioid stewardship moving forward. Next slide. So as you can see, with our excess prescribing, it's common still following surgery, and surgeons have a long way to go. Next slide. There's very little time dedicated to surgical education with regards to pain management. both in medical school as well as residency. And so there is ongoing research, education, and quality improvement initiatives that continue to work to address opioid stewardship within the surgical community. And work has targeted prescribing recommendations for individual procedures, the duration of postoperative hospitalization, and surgical trainees coupled with education. And so those are all different areas that are being pursued to help train the next generation moving forward. And this work is continuing. Next slide. We'll also say that providers continue to be a prime group to target for education and stewardship practices, yet they remain an under-targeted group by outreach. To our knowledge, SCW and Washington State's Better Prescribing, Better Treatment program are the only two programs in the country using state opioid settlement funds to directly target prescribers. And so we just found it interesting that there's only one other group that targets prescribers outside of us using opioid settlement funds. Next slide. So I would say my key takeaways are that death from prescription opioids are as common now as when the opioid epidemic was first recognized. Excess surgical prescribing remains common and is a significant contributor to the opioid epidemic. A procedure-specific approach to opioid sparing or opioid-limited pain management is safe and accepted by patients and providers. And directly targeting prescribers through educational initiatives and collaboratives can accelerate practice change. Next slide. I also don't work in a silo and have not done, a lot of this work is done by a large group of people. And so thank you very much for your attention and to all of the people within SCW that have done this work. That's my last slide, I believe, or next slide, sorry, one more slide.
Well, thank you. Thanks for all of that information. I know you had a lot of resources available in there, and I can see in the chat that everyone is looking at how they can access those resources. So check out the QR code on the screen and the websites that Dr. Bush referenced. But we'll circle back after we have the presentation on the New Jersey PMP for questions. So thanks, Dr. Bush. And Jeffrey, I'm going to turn the presentation over to you. Welcome.
All right, thanks, Angela. Again, my name is Jeffrey Lazick, pharmacist and the administrator for the New Jersey Prescription Monitoring Program, which I'll refer to as the NJPMP or PMP. So let's get right into it. Next slide. The New Jersey Prescription Monitoring Program has been operational since September of 2011, and we've collected nearly 170 million prescription records to date. We collect dispensation records from all New Jersey licensed outpatient pharmacies for all prescription controlled substances and medications schedules 2 through 5, as well as the non-scheduled medications, human growth hormone, and gabapentin. Pharmacies are required to report this data to us on a daily basis, and we receive approximately 32,000 prescriptions every day. It's important to note that we do not collect any prescription records from any inpatient facility, such as hospitals, long-term care facilities, or any other location where a patient is provided with 24-hour care from a supervised healthcare professional. Additionally, we do not collect any information from medication-assisted treatment facilities or substance use disorder treatment facility, and since that information is currently protected under 42 CFR Part 2. Next slide. As I mentioned in my previous slide, we primarily collect dispensation records for controlled substances. Controlled substances were established by the DEA Controlled Substance Act of 1970, which placed each substance in one of 5 schedules based on its potential for abuse, its medical use, and its safety and dependence liability. Notable drugs from each schedule can be seen on the screen. Of course, it's not an all-inclusive list. You'll notice that codeine is found in multiple schedules, which is entirely dependent upon the presence of additional active ingredients used in combination and the quantity of codeine contained in each dosage unit for that particular medication. PMPs were developed largely to help mitigate the abuse, misuse, and diversion of these medications. Next slide. As it was discussed in the earlier presentation, it's well established that many victims of drug dependence begin their journey to addiction with legally prescribed pain medications. What's commonly referred to as the first wave of the opioid epidemic was primarily fueled by prescription opioids. And you can see in the chart on the left that during the first 15 years of the 2000s, prescription opioids were the leading cause of drug-related deaths in the United States. And as a result of that trend, it's during this time also that the majority of PMPs were established across the country. Next slide. In 2017, New Jersey declared the abuse of and addiction to opioid drugs a public health crisis. Drug-related overdose trends in New Jersey mirror those that are observed at the national level. Since peaking in 2021, the annual number of drug-related deaths in New Jersey, the majority of which were caused by opioids, appears to finally be trending downward. Although you should note that the data from the most recent 2 years of 23 and 24 are still pending with the Office of the Chief State Medical Examiner. The decrease is largely attributed to the New Jersey's efforts to increase naloxone distribution throughout the state, and we hear that a lot from our counterparts at the state police. In 2023, there were nearly 20,000 drug-related hospital visits in New Jersey, half of which were directly attributed to opioids. Next slide. Since peaking in 2015, prescription opioid dispensations have dropped 47% over the past 9 years, which of course is most likely due to many factors, including just national awareness regarding the opioid epidemic, updates to clinical practice guidelines regarding the treatment of pain, and implementation of state and specific initiatives aimed at combating prescription drug abuse. Those include, of course, the creation of the PMP, the 5-day supply limitation on initial opioid prescriptions intended to treat pain, and the implementation of prescribing for pain guidelines, among many, many other things, of course. Next slide. The PMP is located within the Division of Consumer Affairs in the Department of Law and Public Safety, which is overseen by the Office of the Attorney General here in New Jersey. Our unique position allows us to maximize the utility of our data. The primary goal of the PMP is to assist New Jersey's healthcare practitioners make the most informed treatment decisions at the point of care by analyzing patients' prescription patterns and presenting relevant clinical summaries. But on a broader scale, the Division of Consumer Affairs, which is responsible for protecting the public from fraud, deceit, and professional misconduct, is able to use PMP data to assist with education, advocacy, regulation, and enforcement. Next slide. So who can access the PMP? Predominantly, all New Jersey licensed practitioners who are able to prescribe controlled substances and all New Jersey licensed pharmacists who are authorized to dispense controlled substances. Prescribers are able to delegate their PMP authority to certain supportive staff from their practice, and those roles can be seen on the screen. Prescribers and pharmacists represent the vast majority of our program registrants. Next slide. To give you a better perspective into New Jersey's prescriber population, we have roughly 95,000 prescribers in the state, of which approximately 64% of them, or about 60,000, have the authority to prescribe controlled substances, meaning that they have a CDS registration specific for New Jersey. Of course, these numbers change every single day. As you can see, the majority of prescribers in New Jersey are physicians. While veterinarians also have a CDS and are required to register with the PMP, they are exempt from using the system primarily because it's not well suited to accurately monitor veterinary prescriptions. Next slide. There's approximately 3,400 pharmacies in New Jersey, with 63% of them being located in state. And while there's around 20,000 pharmacists licensed in New Jersey, only about 8,500 of them are registered with the PMP. Registration for pharmacists is limited to those practicing in a direct patient care role and is predominantly comprised of those in outpatient dispensing settings. Next slide. While prescribers are encouraged to access the PMP prior to prescribing any controlled substance, they're specifically required by state law to do so in the following circumstances. The first time they prescribe any Schedule II medication for acute or chronic pain, the first time they prescribe any scheduled opioid, the first time they prescribe a benzodiazepine, and every 3 months thereafter if they continue to prescribe any of those medications. Also, anytime they prescribe a Schedule II CDS for the treatment of pain to a patient in an emergency department, and anytime that the patient appears to be seeking the controlled substance for purposes other than the treatment of an existing medical condition. Next slide. Prescribers' use of PMPs is specifically documented in recommendation number 9 of the 2022 CDC Clinical Practice Guideline for prescribing opioids for pain. Next slide. Pharmacists are also encouraged to access the PMP prior to every dispensation for a controlled substance, but they're only required to do so if they have a reasonable belief that the patient may be seeking controlled substances for purposes other than the treatment of an existing medical condition. Despite having less strict mandatory patient query laws than prescribers, pharmacists routinely utilize the PMP far more often than certain prescriber licensee groups in the state. Next slide. Use of the PMP is critical for pharmacists to remain compliant with their corresponding responsibility, which is outlined in Title 21 of the Code of Federal Regulations, Part 1306. Next slide. While prescribers and pharmacists represent the majority of our program users, additional state licensees are also permitted to access our system. State and county medical examiners can access the PMP so long as they certify that the request is for the purpose of investigating a death. Also, New Jersey mental health practitioners have been provided access as long as they're providing treatment for substance abuse to patients at a residential or outpatient substance abuse treatment center licensed by the New Jersey Department of Health. Next slide. Utilization of the PMP has grown significantly year over year, and in recent years, that growth has been largely fueled by the electronic health record integration. Last year, 9.3 million patient requests were performed within our system, and 78% of those searches were completed with EHR integrated software solutions. EHR integration saves a lot of time and greatly increases provider compliance with state-mandated patient queries. Next slide. Every state or territory in the US has a PMP, and because of this, we are allowed to connect to one another to broaden our scope, which is very important for a small state like New Jersey, where it's common for patients to travel to New York or Pennsylvania for treatment. The NJPMP is currently connected to 21 additional PMPs, which are all highlighted on the map in light blue, and are primarily located in the Northeast area, Mid-Atlantic region, and along the East Coast, but also includes Puerto Rico and the United States military health system. Next slide. When looking at last year's patient search metrics, it's no surprise that New Jersey health professionals most commonly check Pennsylvania and New York PMPs. Similarly, those PMP users in those states check New Jersey at a high rate. And due to the snowbird migration that we all know about, it certainly makes sense that Florida healthcare professionals frequently check New Jersey's program. Next slide. In addition to medical professionals, the NJPMP database is often sought after by law enforcement, licensing agencies, and public health organizations for the purpose of drug-related investigations. Last year, we responded to nearly 500 such requests, and it should be no surprise that the DEA was the leading responsible agency. Law enforcement agencies are only able to obtain PMP data pursuant to grand jury subpoena requests for bona fide investigations and do not have direct access to our system. Next slide. We're now going to review the process of requesting a patient's PMP report within our online AWARE system. The patient query, of course, is the hallmark of the PMP and allows healthcare professionals to monitor their patients' medication consumption and compliance, make well-informed treatment decisions based on objective data, decrease the possibility of therapeutic duplications and dangerous drug combinations, and identify patients who may be displaying behaviors associated with abuse, misuse, and diversion of controlled substances. Next slide. As previously discussed, healthcare professionals can access the PMP by two primary pathways, our online web portal or direct integration into their electronic health record system. Next slide. This is the login screen for the online web portal. Next slide. When you log into the PMP, you are presented with a dashboard that provides you with a list of any patient alerts, a summary of their most recent patient requests that have been performed, and any recent PMP announcements. As the program administrator, I'm able to utilize the announcements feature to send out mass communications to all of our system users in real time through the online portal, as well as directly to our users' emails. Most commonly, this announcement feature is used to notify healthcare professionals of fraudulent prescription trends, including stolen prescription blanks in specific areas of the state. Next slide. When users select the menu button, they're presented with a drop-down, which contains many functions, but for now, we're going to focus on the patient request. Next slide. In order to complete a patient request, users have to enter a patient's first name, last name, and date of birth. Patient requests are limited to the most recent 2-year period. As mentioned earlier, users are able to simultaneously check the other 21 state and territory PMPs that we share data with. Most importantly, all users must certify that the patient request being made is for the purpose of providing healthcare to that patient. The certification is important and must be completed every time to protect patient privacy and uphold data confidentiality. Next slide. The top of a patient's PMP report summarizes the patient's demographics and includes a summary of the addresses that patient has used when filling prescriptions. PMP reports are displayed in a tile view with multiple tiles highlighting specific attributes of patients' medications, prescribers, and pharmacies. These tiles are intended to assist healthcare providers absorb a large amount of information quickly and easily and focus their attention on important metrics. Every tile is interactive and will display additional details when prompted. The RX graph is particularly useful since it displays a graphical timeline of the patient's prescription history separated by prescriber and drug class, which allows practitioners to easily identify drug overlaps and potential therapeutic duplications. Additionally, the state indicators tile, which is also referred to as clinical alerts, identifies patients who meet one of 4 potentially dangerous thresholds that may increase their risk for drug overdose. If a threshold is met, the gray icon turns red and displays an exclamation point. Let's review the state indicators in a little more detail. Next slide. If you click on the details button in the state indicators tile, it will enlarge to provide the specific metrics which must be met in order to trigger the alert. Combination therapy with opioids and benzodiazepines is self-explanatory and will trigger if there is an overlap between those 2 medication groups in the patient's profile. Both the consecutive day threshold and the morphine milligram equivalent threshold are set to 90, and the multiple prescriber and pharmacy threshold is set to 4 of each within a 90-day period. The behaviors highlighted in this section have been shown to potentially increase patients' risk of experiencing an overdose and should be incorporated into the clinical assessment performed by the healthcare provider. Next slide. As you continue down the patient's report, you're presented with additional graphs for MMEs, which makes it easy to identify potential high dosages resulting from concomitant opioid therapies. Again, all of these graphs are interactive and provide additional information once specific sections are selected by the user. You can see if you hover over a particular section of the RX graph, for instance, that it will display a pop-up window outlining the fill date, drug name, quantity, day supply, prescriber, and pharmacy name associated with the prescriptions filled during that specific period of time. Next slide. Continuing down further, you'll see a large prescription summary tile, which provides high-level metrics separated by drug class, including the current quantity of narcotics the patient should have in their possession at the time of the visit and their current daily MME. As you near the bottom of the report, practitioners are presented with traditional view of an Excel-like version of the previously viewed graphical timeline. Users can easily view fill dates, written dates, drug names and strengths, quantities, day supply, prescriber, and pharmacy details, as well as payment types and identification of which state PMP that data is being sourced from. Next slide. The final sections of the report provide summary tables of all the patients, prescribers, and pharmacies, as well as the names and relationship of individuals picking up that patient's prescriptions if available. Next slide. In addition to patient prescription report, the PMP also contains valuable information to assist in patient education and referrals. This can be accessed by clicking on the Other Resources button. Next slide. One of those resources is a tool where system users can enter in a patient's zip code to generate a list of the 30 closest Medicaid-assisted treatment facilities, which includes their addresses and phone numbers. This list can be printed out and provided to the patient if the healthcare practitioner identifies a patient who's willing and ready to participate in substance use disorder treatment. Next slide. Here's just a sample of what that treatment provider list looks like. Next slide. Additionally, the PMP contains several printable flyers linked directly from the CDC's website, which highlight various important aspects of opioid treatment. Next slide. Another important feature that's available within the PMP is a tool that's called the MyRx report. Next slide. The report is linked with the DEA registration number associated with the prescriber's PMP account. Prescribers are able to create a report to view all prescription records submitted to the PMP that are associated with their own DEA number for the most recent 2-year period. Next slide. The MyRx tool allows prescribers to easily identify potential cases of prescription fraud or pharmacy data entry errors, and is especially useful when a prescriber has their prescription pad stolen or suspects that someone may be utilizing their credentials to order fraudulent prescriptions. We encourage prescribers to utilize this feature as often as possible to minimize the potential for illicit behavior. Next slide. Also, users can set up default states for the multi-state function so that they don't have to select each state specifically each time they perform a request. Next slide. It's most common for our users to select our border states of New York, Pennsylvania, and Delaware for defaults. It is strongly recommended for users to make targeted and informed selections rather than simply selecting all states to minimize the likelihood of identifying false positive results, especially for patients with common names. Next slide. The PMP Aware system has a lot of additional features and educational resources available that we just don't have time to cover today. And I encourage all users to explore the program's menu to take advantage of everything it has to offer. Next slide. Earlier in the presentation, I mentioned how the Division of Consumer Affairs is able to utilize PMP data to assist with education, advocacy, regulation, and enforcement initiatives. The PMP enables data-driven policy and collaboration. It aids in the development of targeted interventions, and it strengthens drug-related investigations with evidence-based intelligence. The DCA collaborates with many entities for statistical research and educational purposes. We're going to review a very small selection of data trends that have been observed by reviewing NJPMP data. Next slide. One of the data points collected by the PMP is the method in which prescriptions are prescribed. New Jersey is one of only a handful of states remaining in the country that has not passed any legislation regarding electronic prescribing, despite having a bill that was introduced to the legislature back in 2016. So even though that bill has been pending for nearly a decade, the adoption of electronic prescribing has happened organically, and last year accounted for at least 72% of all prescriptions monitored by the PMP. Back in 2017, electronic prescribing frequency was only at 11%. Next slide. As I discussed earlier, opioid prescriptions in New Jersey have declined nearly 50% since peaking in 2015. A decline can also be observed for benzodiazepines, which you can see are now the most commonly prescribed controlled substance class and have been since 2020. Conversely, prescription stimulants continue to rise year over year, although the rate of increase for New Jersey is well below the national average. We can use this information as a starting point to further explore stimulant data more closely to identify patterns and shared prescription characteristics. We can check a variety of variables, including prescriber specialty, the patient age group, patient gender, pharmacy, prescriber, and patient locations, and so on. These additional details may reveal key metrics that are driving specific changes in prescribing behaviors throughout the state. Next slide. If we look at the volume of the top prescriptions dispensed in New Jersey by active ingredient for the past 2 years, you'll notice that the list contain the same medications, just in slightly different orders. There's a relatively even array of medications from multiple drug classes, and it's no surprise that gabapentin is in the top spot since it's not a controlled substance, and thus has far less restrictions on its prescribing allowances. The reason that I include this list as a top 11 rather than a top 10 is so that we can highlight the prevalence of buprenorphine naloxone prescribing. The PMP monitors this list occasionally to identify any drastic changes which may be indicative of updated practice guidelines, increased identification of previously untreated conditions, or even potential cases of substance misuse. This slide shows prescription dispensations, and we're going to look at the next slide, which will show us prescription volume by dosage unit. Here you'll see essentially the same active ingredients involved, but you're going to see much larger differences in quantities, especially with gabapentin. And again, that is largely due to the fact that it's not a controlled substance, and because its typical dosing conventions often require very large quantities of pills to be dispensed per prescription. Next slide. If we drill down a bit further to look at the individual drug product rather than the active ingredient, we'll notice a slight change of this list. Opioids and stimulants are less represented, and the benzodiazepines expand. One of the most positive takeaways from this detailed view is that the most commonly prescribed drug products in New Jersey are low dosage and immediate release formulation, which reflects well on our practitioners' behaviors and aligns with key recommendations from state and national guidelines. Next slide. When looking at per capita opioid consumption ranked by the highest dosage, as represented by morphine milligram equivalents for the last year, we can see that 3 zip codes in Camden County take the top spots. Similarly, we see that 3 zip codes from Ocean County also take spots in the top 10. With Hudson, Gloucester, Atlantic, and Cumberland counties each taking 1 remaining spot, it's clear that South Jersey residents appear to be consuming much higher dosages of opioids per capita compared to North Jersey residents. Again, we can use this as a starting point to guide more in-depth analysis, and it also allows us to coordinate with local public health officials and healthcare organizations in these potential at-risk areas to implement targeted interventions. Next slide. This chart essentially provides a much more detailed view of the previous map by revealing specific opioid metrics for each county. And as you can see, as indicated by the red text, the South Jersey counties, again, have the highest percentage of patients per capita receiving opioid therapy. You can see that these counties also receive the highest number of opioid prescriptions, the highest number of opioid dosage units, and the highest opioid dosages, and the highest opioid day supply compared to the rest of the state. Next slide. On this slide, the left chart represents the total opioid prescriptions per patient, while the right chart represents the opioid dosage, all separated by county for specific age bands. You'll notice that the red text continues to be the most prevalent in the southern counties, specifically Burlington, Camden, Cape May, Gloucester, and Salem, and also the most common patients receiving opioids are between the ages of 35 and 64 years old. Next slide. Since we talked about opioid and benzodiazepine combination therapy earlier, I wanted to provide a high-level overview of its prevalence throughout New Jersey. I know this slide is very busy, but you can see that last year, 11,506 total prescribers prescribed that combination to 73,316 total patients. You can also see that the most common prescribers of this combination were practicing in Warren, Hunterdon, and Salem County, but the patients most commonly receiving this combination resided in Camden and Gloucester counties. Female patients represented approximately 62% of this combination, with males at 38%, and those in the 35 to 64-year-old age groups demonstrated the highest number of overlapping days of this combination therapy and also visited more prescribers to receive this combination therapy compared to all those in the other age groups. All the data that I've shown you and I've discussed represent just a very small fraction of what we are able to do with our data and how it can be used for public health and epidemiologic purposes. Hopefully, though, it has illuminated a different but equally important role for the PMP beyond its critical use as a clinical support tool for the healthcare professionals. Next slide. We don't have time to go through opioid-related regulations for practitioners. I did want to include, there's about 10 slides here I'm not going to go over. Since all the state's health professional boards are located within the Division of Consumer Affairs, just like the PMP, we work very much in a coordinated partnership. The list of regulations I've included here certainly are not all exhaustive, but I did want to include them so that you have time to review them on your own. I know these slides will be shared. So I just highlighted a few important state regulations regarding opioid practices in the state. There's a lot of them surrounding prescribing, dispensing, and administration of controlled substances. Many people say too many, and I hear that a lot from the community at large. But if you really spend some time to read them, you typically find that the majority of the rules are very much aligned with national clinical guidelines and common sense professional behaviors. So you could skip through that final practice and we'll end there and open it up for questions.
Thanks so much. I think it was really comprehensive information. I appreciate you adding these additional slides. As everyone has seen in the chat, a copy of the slides will be made available to everyone, as well as a recording of this presentation. And while Jeffrey wasn't able to get to those slides, they are a great resource. So we appreciate you sharing them with us. Um, I'll go to my first question, and I will send that question over to you, Rebecca. Can you talk about how, what the basis is or the data that's used when you're recommending the amount of opioids prescribed for specific surgeries?
Sure. So a lot of that data, or where we draw that data from our prescribing guidelines, has come from studies that have been published. A lot of it comes from the Michigan Open, so the opioid prescribing network data that is out there. Otherwise, various surgical prescribing, various surgical society bodies based on data, patient survey, and it's not just like, people in a back room choosing a number. It's meant to, in theory, satisfy or meet. The goal is, I believe, over 80% of patient needs. So that 80% of patients are satisfied by that tablet amount. Again, in opioid naive patients.
Thanks. And Jeffrey, I know you talked about the difference between North Jersey and South Jersey in terms of opioid prescribing, and we have a number of people who are on with us who are not from the state of New Jersey, but the population difference within the northern part of the state and the southern part of the state is significant, right? There's more people in the north. So can you, is there any additional insight or next steps? I know you mentioned that you could use that for additional research. Any reasoning that you have that you could share with the group on that? Any thoughts?
No, I mean we typically, like I said, we'll coordinate with the local representatives from those areas. Of course, they are much more interested in figuring out why those trends exist, right?
Yeah,
Like you said, very obviously, there are certainly a whole lot more people living in North Jersey than South, so that's definitely going to skew. I mean, we do per capita analysis to try to minimize that as best we can, but there's still less. I mean, the areas in Southern Jersey are much more rural, right? We know that. We know the issues that go along with that, potential lack of access to certain types of care. Um, Certainly, education becomes part of the issue as well. When you look at those areas and just knowing what resources are available in the South compared to the North. Um, and so I think a lot of that plays into it for sure. And it's definitely something that like I said, local representatives from those areas certainly reach out to us to find out, to try to help piece that puzzle together.
absolutely. And Dr. Bush, you mentioned also within your presentation the limitations on rural areas and additional prescribing that may occur there, correct? Lack of access to alternatives. Anything you want to add on that?
think that's, still an area of active research looking at how to, what is the best, you know, uh, what is the best way to manage patients that have limited access to care. And, one of my colleagues, Tudor Borza, is doing further workup and or further research into that and looking at different access, and particularly in rural populations, and how do provider practices change or differ for patients in those populations.
Absolutely. I know we're coming to the end of our time, and a survey has popped up a minute or so ago. So we appreciate you giving us your feedback on today's presentation. I want to go to our expert panelists for one final thought before we end. But I did want to just bring everyone's attention. Information is on the screen on how to access continuing education credits. So you can see that information um, on the screen right now. So I just wanted to bring your attention to that. But Rebecca, I'll go to you for a final thought with all of our attendees today.
Um, just general final thought. I mean, I think
Just one, yeah, something. Just if you could wrap up one thing that you hope that everyone takes with them today.
sure. I think prescribers are an appropriate audience for ongoing education, and that it's not something that's taught in medical school, and further education is necessary, and that we're seeing the effects of that education increasingly in practice, which is moving in the right direction.
Absolutely. And for those of us, those people who aren't practitioners or prescribers who are on with us, just to feel empowered to have those conversations, right, with their doctors to get that, information to get the best care for them. And Jeffrey, just going to you for final thought on the day, what everyone could take with them.
Sure. Yeah, I mean, there's a million things, but uh, something that I guess sometimes gets misconstrued, certainly with the PMP and prescription opioids in general, that we see a lot of is potentially overly restricting use of opioids, right? It's certainly not the intention of the PMP or really any of a lot of the state regulations. It's just more about educated approaches to using the opioids, right? And so something that we've seen, unfortunately, and what we hear a lot about from patients who call us directly or speak to us, and even prescribers, is that prescribers are afraid to prescribe it. Patients are running out of opportunities to receive it. And that's a very complicated situation that has somewhat grown, obviously, out of the national awareness and response that has kind of occurred because of all of the attention that the epidemic received. And so there's certainly a much better way to approach managing pain and prescribing opioids, which is really the hallmark of what all of this is about, and trying to get that education out there. I know Dr. Bush talked about education. We talk about it constantly, and it really is so very important. And nothing is black and white ever in this area. And so a lot of those factors always have to be taken into account. And yeah, I'll leave it at that.
Absolutely. Um, Education is key, right? As we try to develop these solutions and get raise awareness among our prescribers and the patients, right? So thank you both for being with us. I think both of your presentations were just so helpful and just had such great information. So thank you for being with us today, and thank you for all of our attendees. Appreciate you joining us, and hope that you will. Be with us next month. We'll be discussing treating trauma to achieve recovery on Thursday, September 11th. So hope you can be with us. Thank you again to our expert panelists. Thank you again to all of our attendees and everyone. Be safe with the weather wherever you are. You know, there's storms traveling throughout the country. So sending everyone well wishes. Enjoy the rest of the summer, and we will see you again, hopefully in September. So have a great day, everyone.